Hey everyone, welcome back to Discussions with Dr. G, where we chat about why our heads hurt and what exactly we do about it. I'm Dr. G, your favorite, slightly sarcastic Gen X nurse. You know, the one who can recite the difference between beta blockers and calcium channel blockers in her sleep, but still somehow forgets where she left her coffee. So let's kick it off. Headaches. They're like everywhere. Seriously. Headaches are one of the most prevalent disorders globally. I mean, if you look around a nursing unit, at least a couple people are going to give you that, "Don't talk to me, I've got a headache" look. These little monsters can wreck your quality of life, tank your productivity at work, and oh yeah, make you rack up a solid bill in terms of healthcare visits and acetaminophen receipts. Now the fun part. Not all headaches are created equal. We're dealing with four big ones: tension headaches, migraines, cluster headaches, and sinus headaches. And the kicker? Treatment totally depends on which kind you are unlucky enough to have. One size fits all does not apply here. Trust me, I once tried to teach a lecture with one of those behind the eyeball migraines, and let me tell you, the decision between can I finish this class or should I just curl up under my desk for a nap was very, very real. Anyone who's lugged their way through a double shift with a headache knows exactly what I'm talking about. So how do we tackle these beasts? Medications, of course, but not just one kind. Oh no, there's a whole wide world of buffet options, and each has its place in the headache hierarchy. Let's set the scene. You've got a patient, or maybe it's you, or maybe it's your Aunt Linda, complaining of a headache. But a headache isn't just a headache, right? It's like saying, I have a car problem. Okay, but is it a flat tire? Is your engine on fire? Did you forget to put gas in? As nurses, step one is always to classify the type of headache. We have to distinguish, what are we dealing with? So, first up, tension type headaches. These are classic. Think tight band around the head, kind of like wearing a headband a size too small, but not stylish at all. Usually mild to moderate, both sides of the head, and not really made worse by moving around. Triggers: stress, skipping lunch, sleep deprivation. Basically, nursing school. Pathophysiology-wise, we're looking at peripheral nociceptor activation, and some CNS sensitization, plus the ever-popular serotonin imbalance. For this, we start with the basics: analgesics, like acetaminophen, which is fine for mild or moderate tension headaches. It's the kind of gentle, non-confrontational cousin in the medicine cabinet, great for dull pain, but no real anti-inflammatory action, so don't expect miracles for migraines. Then you've got NSAIDs like ibuprofen and naproxen. These are awesome for episodic tension headaches or acute migraines because they stop your body from making those pesky prostaglandins that fuel pain and swelling. Don't overdo it. Unless, of course, you like rebound headaches and you know the potential for stomach issues. By the way, if your patient has GI issues, kidney trouble, or is pregnant, or is at risk for bleeding, NSAIDs are a no-go. So always check your facts, folks. Chronic. Though we bring in the big guns, tricyclic antidepressants like amitriptyline. These help prevent chronic tension headaches and migraines, working through neurotransmitter magic. But before you get all excited, remember, suicidal thoughts, lots of sedation, and anticholinergic fun, plus the possibility for arrhythmias, especially in older folks. So basically a fun little package of risks to watch out for, especially in people under 24. So what do we avoid? Opioids and muscle relaxants. Tempting for folks, but super risky for dependents, and honestly, they don't really work all that well for a tension headache anyway. Migraines. That's a different storm. Migraines usually announce themselves with a throbbing one-sided pain, can last from 4 to 72 hours, rude, and can be severe enough to have you in a dark room wondering if the lights went out or if you're just losing it. You might see auras, get really sensitive to light, maybe even smells, and let's not forget the nausea. Physiology here, we're thinking lower serotonin, more CGRP, vasodilation, and neuroinflammation. Trust me, it's a party no one wants an invite to. Migraines are like the pain for the Olympics in terms of medication choices. Acute attacks, we're going for triptans, like sumatriptan or zolmitriptan. Ring any bells? They're serotonin agonists, which try to fix that whole serotonin deficiency. Triptans are awesome for acute migraine and cluster headaches, but don't use them in anyone with heart disease, hypertension, or hemiplegic migraines, as they can cause chest tightness and even raise blood pressure. And of course, if you mix them with SSRIs or SNRIs, you're increasing the risk for serotonin syndrome. Dietans are similar but don't clamp down on blood vessels, so they're safer if your patient's got cardiac history. Beta blockers? Think metoprolol or propanolol. Fall in the preventive migraine camp too? They chill out your blood vessels and reduce frequency or severity. Just don't give them to anyone with asthma, COPD, or really slow heart rates unless you want to see the world's most unhappy pulmonologists. Oh, and let's not forget Botox for chronic migraines. Yes, you heard me. Neuromuscular blockers, also known as a neurotoxin, injected right around the head and neck that tell the aching muscles to chill out and stop sending pain signals. Cluster headaches are on a whole new pain scale. Never had one, but I saw a client holding their head, tears streaming, nose running, and eyelids drooping. It's always one-sided, centered around the temple or eye, and it's severe. Like, people describe it as a stabbing style of pain. They come in groups, hence cluster, and maybe sometime daily for weeks, okay? It's got something to do with trigeminal nerve activation and the hypothalamus. If you ever see someone with tearing, nasal congestion, and droopy eyelids, cluster should be high on your list. Meds, same as migraines. Now, CGRP inhibitors are the new, cool, fancy migraine medication, like erbrogipant. Science sounding, right? But really it's just a new fancy absorptive Japan for acute, and don't forget the monoclonal antibodies like erinumab. They block the chemical that makes pain pathways go crazy. Risks aren't terrible, but watch that liver function, and there can be some allergic reactions too. Remember, NSAIDs or acetaminophen can help for some migraines and cluster headaches too, depending on how bad things are. We also have calcium channel blockers like verapamil. These are good for treating cluster headaches and some migraines. They also cause blood vessels to relax. But hey, you gotta watch for swelling and super slow pulses. Don't worry, the drug buffet continues. Anti-seizure meds like gabapentin, valproate, or topiramate. These stabilize those neurons, helpful for preventing some types of migraines and cluster headaches. The downside, they can zonk you out, make you gain weight, cause dizziness, and don't forget, there's a risk for suicidal thoughts. Not exactly a walk in the park, but they can be useful when needed. And then sinus headaches. Oi, 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 those can fool folks. There's pressure in the face, worse if you lean forward, stuffy nose, maybe gunky drainage, usually linked to some sort of infection or inflammation in the sinuses. Totally different vibe than the other ones, okay? For sinus headaches, sometimes you see decongestants like pseudoephedrine or phenylephrine. These shrink your nose's blood vessels and relieve pressure. But in folks with hypertension or heart disease, these are not always ideal, as they can ramp up the blood pressure and keep people wide awake at 3 a.m. So let's double check that med list. Maybe it's not congestion. Maybe it's really is allergies causing the sinus headache. For this, you're going to need antihistamines. Again, this is the only time you're going to use allergy-related sinus headache medication. It is not for migraines, not for tension headaches. Got it? Good. They block histamine, calm congestion, but don't expect them to do anything for that pounding migraine you got from your arguing with your insurance company, okay? All right, what I'm trying to get at here is that you need to treat the root cause. Infection, inflammation. So if it's a legit bacterial infection, you're going to get antibiotics like amoxicillin. Okay, decongestants, NSAIDs, and acetaminophen help with the symptoms, but if it's viral, hold thy antibiotics, please. Okay, let's zoom in on what nursing brings to the headache party, because let's be honest, nobody can mess up or fix a med order quite like a nurse. First, you got to properly assess what kind of headache are you dealing with? How often are you getting them? What triggers them? Okay? A good baseline can save you a world of trouble, not to mention stop providers from just flinging meds at the problem. Then comes the monitoring. You got a patient with GI ulcers, kidney issues, liver issues, maybe a psych history. You better know before reaching for that medicine cart. You hear me? And don't forget to look out for signs of medication overuse. Yes, rebound headaches are a sign of overuse. Too much of a good thing is, well, still too much. Here's my favorite. I once had a patient who would hoard her triptans all week and then binge them on Saturday night so she wouldn't ruin the weekend. Not how it works, people. That's where nursing steps in, not just to pass the meds, but to make sure the education sticks and that people use their treatments the way that they are intended. All right, let's be real. Half the med battle is making sure people know how and when to use what you've given them, right? Education is key. We've got to help clients find their triggers, whether it's stress, lack of sleep, sketchy diets, hormonal swings, because avoiding those is sometimes the best medicine. With meds, limiting analgesic or NSAID use. Otherwise, rebound headaches are coming for you. Overuse is a massive trap, especially with NSAIDs, triptans. You hear me? Stick to the rule. No more than 10 days a month, folks, or you're risking turning that occasional headache into an every other day horror. And if you're on preventatives, that means consistency, not just when the headache fairy pays a visit. Always report new chest pain, severe GI upset, bloody stools, new depression, a weird rash, or any vision or speech changes. This stuff matters. And because medications only get you so far, don't skip the lifestyle education. You got to teach your patients to drink water, get some sleep, find their triggers, do whatever they need to do to decompress. I once had a patient who kept a headache diary for a month. Okay? Turns out every headache hit the morning after a cheese binge. Sorry to all my cheddar fans out there, but yeah, sometimes the answer is right in front of you in the dairy aisle. Now we get to the fun part, using that clinical judgment muscle. Whether you're in the ER, clinic, or standing in the kitchen while your cousin describes his new mystery headache, nurses have to spot the problems. What kind of headache? What are the triggers? Are there any red flags? From there, it's about matching the right med to the right person. Safety always comes first. Screen your triptan candidate for heart problems and maybe avoid TCAs if there's a psych risk. Teaching and monitoring don't end after you hand over the pill cup, and making sure those patients know the drill and when to call for something scarier like serotonin syndrome or sudden chest pain is ultimately the end game. All right. That is a wrap for today's walk through the world of headaches and their many, did I say many? Treatments. If you've made it this far, congratulations. Remember, the next time you got a headache or you're taking care of a patient with one, think about the type, the meds, the risks, and all those nursing pearls we just talked about. I'm Dr. G. Thank you for joining me on this Discussions with Dr. G fiasco. I'll catch you in the next episode.